All right. Welcome and thank you for joining us at this cross-sector task force to address overdoses in Nevada meeting. This is a joint meeting of the Advisory Committee for Resilient Nevada and the Substance Use Response Working Group. And we are going to start with working out some technical difficulties, but we'll move to taking roll call and establishing a quorum. Attorney General Ford was originally supposed to chair this meeting, but he is out today because of the illnesses that are going around. So I'll be the chair for this meeting. Is it Joan or is it Kelly who will help with roll today?
Actually, I'm going to help with roll. I have it in front of me. So I'm just checking the attendees that are coming in so that I can elevate them to panelists if they are in fact members. So great. I'll be doing that while we also working to resolve any issues we have in Carson. Okay. So if you just give me a minute, I'll be going through that list and I think I'll let you know when I'm done. Although it's an ever-growing list. We're getting more and more people.
Thank you.
Attendees can now hear you.
Yeah, the committee members will just bear with us. The public has the same thing. Just a minute or two while we work on technical difficulties and confirming that we have all the members of this task force in attendance. I am also seeing a couple of the ACRN committee members on screen, but they have different names than their actual name. So just wanted to confirm that we're aware of that. Cool.
So I see that the person labeled as Melissa Hardy says, I don't know who you are, so if you don't mind actually telling me. Okay, great.
I also have a message from Dr. Wagner that says her link is not working and she's looking for some guidance on how to get in.
She's on here, Sanchez.
Oh, sorry about that. There you are. You're right in the middle. Sorry, thank you. Okay. Looks like we're getting a little bit closer.
Yes, I think so. Deanna, are you working through the attendees? I only had to promote one person.
Yes, I have. I've promoted a couple as well.
And I actually have done it, but it isn't seeming to work. I promoted Tina Dortch, but
yeah, I did too, and she didn't come up.
She still is in the attendees list.
Hi, I'm actually subbing in for Tina. Myself and my colleague, Karina, are attending as supporters for the NOMI office.
Okay. I think we might need, oh, sorry, Tina, is that?
Hello, everyone. I'm not a member of ACRN, so I didn't know if I was supposed to be a panelist. I'm sorry. Sorry for the
Thanks.
confusion, but I'm not a member of ACRN.
Okay, thanks for checking that. I did have you on our list, so I think we're set.
Should I stay in this mode or should I go back to the public facing mode?
Yeah, we'll go back to the public facing mode if you're not sitting in for Tina, I would say.
That was Tina who was speaking.
No, that is Tina.
Sorry. Hi, Deanna. This is Tina. My camera's on now. I'm sorry.
Okay, sorry about that.
But I don't know. My two staff people can definitely drop into public mode, but just confirming for the record that as a non-ACRN member, should I be public or should I be panelist?
You can be listed as an attendee. I think I can change that now, or Bill might be. So I'll just.
How do you change your name? How do I change my name?
One second, I can hopefully change it for you. Actually, maybe Deanna's still on and she can change it and we can get to our agenda and roll. Awesome. So that was the person listed as Arnold Thomas, and Deanna, you'll see in the chat.
Is actually
Brittany.
Brittany.
Is Brittany.
Okay, got it.
So Crystal, I also see that there's a Zoom user asking, like raising their hand. I'm wondering if it's somebody who is a panelist and if we should allow them to talk and let us know. Do you see that?
It's me, Debbie. I can't get in for some reason. That's my hand raised.
Thank you, Debbie.
Thank you, Debbie. I'm going to promote you and hopefully find you in that list too.
I'm in, thank you. Darcy's trying to get in too from the ACRN. She can't get in.
Okay, Darcy. And we also have someone that I just need to know your name. If you were if you're listed as LV 4500, we just want to have your name correct.
LV 4500 is the Las Vegas conference room.
Okay, sorry. Okay. I think we're set, Chair. So if we want to proceed with the PowerPoint and taking roll, we can give that a try.
All right, great. Thank you, Crystal. So yeah, I'll call this meeting to order and we will start with establishing quorum and completing the roll call.
Okay. Aaron Ford.
He's out sick.
Angela Nichols. Arnold Thomas. Ariana Saunders.
Here.
Brittany Collins Jefferson.
Present.
Cecilia Maria. Chelsea Cheatham.
Present.
Christine Payson. Claire Thomas.
1 second, Crystal. I see Christine Payson on.
Okay.
So maybe we can come back to her and ask her to unmute and just put her in at the back of the line and circle back.
Okay. Claire Thomas. Cornelia Sheehan. Darcy Patterson.
She was trying to get in. I don't know if she's sick, but I know she's trying to get in.
Okay. I think Deanna's helping work on that. And I forgot to mention, as we're doing roll call, if you could put your camera on so that we can add that visual as part of the attendance, that's very helpful. David Sanchez.
Present.
Don Yohey.
I'm here, but I'm not on the SURG or the ACRN. So.
Yeah, my list isn't sorted. I'm sorry. So I'm trying to think through who I do know. Okay, so Debbie Nadler.
I'm here. Thank you.
Thank you, Debbie. Elyse Monroy.
I'm here. Thank you.
Eric Schoen.
I'm here. Thank you very much.
Fabian Doñate. Dr. Farzad Kamyar.
Present.
Dr. Fayez Kadir. I do see some information in the chat. We aren't able to utilize that information in the chat, so I just would need Dr. Kadir to verbally acknowledge if they're present or not.
Crystal, I believe he's a presenter, not a ACRN or SURG member.
Sorry.
It's okay. I don't know, Dawn, since Joan isn't here, do you have the list of just the ACRN members?
Yeah, I can get it. Hold on.
Would that mean we'd have to start over? Because if it might be easier to just keep going down this list and bear with me.
Just keep going, Crystal. You're fine.
Okay, just bear with me. I might have some names that are not relevant. Gina Flores O'Toole. Heidi Sievers Gansert. Henna Rasul.
I'm the attorney for the
That's
task
right.
force.
Okay, thank you. Jamie Ross.
Present.
Jeffrey Iverson. Jessica Barlow. Jessica Johnson.
Present.
Carissa Loper.
Present.
Dr. Carla Wagner.
Present.
Catherine Loudon. Leslie Dixon.
Present.
Lenetra Grady.
Present.
Lisa Lee.
Sick but present.
Not remember. Melissa Hardy. Michelle Berry.
I'm present, but I'm not a member of either unit.
Pauline Sala.
Present.
Quinny Winbush. Ryan Gustafson. Shayla Holmes.
Present.
Dr. Stephanie Woodard. Steve Shell.
Present.
Tawny Chapman. And Terry Kerns.
I'm present, but not a member.
And I see that there's a few things in the chat. So Dr. Kadir, but they are muted. Okay, I see what you're saying. I see how you've been waving to us. Sorry about that. You should be able to be unmuted. It doesn't look like you're muted on my end or yours, Dr. Kadir and Lori. Okay, I think we could mark Dr. Kadir as present if that's okay, Henna. I'm not sure why Oh, are you listed? Sorry. Lori and Dr. Kadir, are you listed as a 208 phone number? Okay. Dr. Kadir, can you indicate
Hi,
your
can you hear
presence
us?
for them? Yes.
Hi, this is Lori and Dr. Kadir. Can you hear us now?
Yes.
Okay, great. Thank you.
Thank you, Lisa. Going back up our list, Christine Payson.
I am here. Can you hear me?
Yes, we can. Thank you.
Oh, good.
And as we were going through roll, we may have had additional attendees that we needed to move to panelists. If you are a member of the ACRN or the SURG and I did not call your name and you've been moved to a panelist, you should now be able to indicate you are here. So if you could do so now with your name. And Deanna, have you elevated everybody that you can see as a member?
I have, and I'm just going back through the list again. I have not had contact with Carson, with Joan.
And she has a member present with her. I think we might need guidance. I'm pretty certain we don't have a quorum. I have 17 yeses. I'm not sure because my list wasn't accurate for members, what the total number of members across both bodies is to establish a quorum. Don, do you have that information?
Yeah, that's what I was going to ask. I think we can maybe use Don and Terry to come up with a list of each individual committee and then add those numbers together, maybe.
Thank you everyone for bearing with our technical and other difficulties.
Yeah, it does look short for sure as far as quorum.
Can I make a motion that we move the date of the quorum? This is Debbie Nadler for the record. Sorry.
No motions can be made because it's not a meeting, and it's not a meeting. There has to be a quorum to start a meeting.
Sorry.
You're good. Let's give it another couple minutes to confirm that we either do or we do not have quorum, and we'll move forward from there.
Do you mind? Do you mind if I just take a roll of just the ACRN, and then Terry, if you could just take a roll of the SURG?
Perfect. Please. Thank you.
Jessica Barlow. Brittany Collins Jefferson.
Present.
Lenitra Grady.
Present.
Ryan Gustafson.
Present.
Dr. Kemiar.
Present.
Carissa Loper.
Present.
Catherine Loudon. Dr. Wagner.
Present.
Cecilia Maria. Elyse Monroy.
Present.
Darcy Patterson. Pauline Sala.
Present.
Chair Sanchez.
Present.
Ariana Saunders.
Present.
Cornelius Sheehan. Jamie Ross.
Present.
Winnie Winbush. You have a quorum of your ACRN.
Okay, we'll now run through the SURG committee members. Chelsea Cheatham.
Present.
Angela Nichols. Leslie Dixon.
Present.
Senator Donyate. Aaron Ford. Not present. Shayla Holmes.
Present.
Jeffrey Iverson. Lisa Lee.
Present.
Debbie Nadler.
Present.
Christine Payson.
Present.
Eric Schoen.
I'm present.
Steve Shell.
Present.
Claire Thomas. Melissa Hardy. Dr. Woodard. Senator Severs Gansert. Jessica Johnson.
Present.
9 people, 8 missing. So thank you.
We have a quorum of SURG members present.
Very good. Thank you, Terry and Dawn, for confirming that. Crystal, I'd just like to verify with you that we're in agreement that we have quorum for this meeting and we can move forward as a meeting.
Yes.
All right, thank you. Dawn, can we move to agenda item number 2, please? I have Debbie Nadler with her hand up. Debbie?
I was just raising my hand for public comment.
Okay, I'll call you in just a sec. So agenda item number 2 is public comment. Public comment will be received in person at either location, or it can be added on via Zoom. In consideration of others who may wish to provide public comment, please avoid repetition and limit your comments to no more than 2 minutes. Again, no action may be taken on a matter discussed under this item until the matter is included on an agenda as an item on which action may be taken. Written public comment may be submitted as well to the task force, and it can be included in the meeting minutes. Just a heads up, I am going to be pretty rigid on the 2 minutes. So we'll start with public comment, and Crystal, if you can help me navigate, but I'll go ahead and start with Debbie Nadler for public comment.
Sorry, thank you, and I am keeping it short. I just have a couple questions, and I'm not sure if this is a public comment thing, and I'm sorry, my Zoom's not working good. We received the Mercer recommendations via email, and literally I read through every page, and I have a question regarding the expenses and how much we paid Mercer, because I still have yet to see, and I don't know if the other committee members have seen actual dollar amounts that have been spent. And I'm not sure if Mercer gets paid at the end, in the middle, in increments, or what. But because a lot of the stuff that Mercer presented in their recommendations were taken from Johns Hopkins, which was already written. So I just was a little curious why we were paying. I'm sorry, did I go over my 2 minutes?
No, you're good. You're about up though. You good? Or do you have any more?
I just had one other question, and the question is, as far as the SURG committee, and maybe I need to talk about this tomorrow. I feel like we've invested our time 2 years into this at least, and if our term is up in the mid-quarter of 2023, it's kind of like taking the quarterback out before the Super Bowl. So if we could work on that, extending our time, being on the committee, I'd appreciate it. But I didn't know where to bring that up. But yeah, that's all my public comment. Sorry.
Thank you, Debbie. Unfortunately, we can't answer questions during public comment, but I would advocate for you to reach out to Terry with your questions about SURG, and yeah, maybe keep that first question on the top of your mind as we work through the rest of today's meeting. And again, another question that might be directed towards Terry. Do we have anyone else interested in speaking as part of public comment number 1?
If you're joined virtually, if you can just raise your hand, and then after that, we'll go to people who have joined only by phone. So if you have public comment and you've joined virtually, please use the raise hand function of the webinar to indicate that you'd like to speak.
Crystal, we have a public comment here in Vegas as well.
Okay, Chair, I don't see anyone raising their hand. So if you want to go to in-person public comment, please.
Yeah, we'll move fluidly as they come up. So right now, if we have one available in Las Vegas, I'd like to ask that person to come forward with their public comment.
Giuseppe Mandel, representing There's No Hero in Heroines, Alternative Peer Group Las Vegas, peer group for adolescents in recovery and opioid awareness and prevention. Thank you for allowing me to be here, and just here to learn from everything you and operating my lived experience and services that I can help.
Great. Thank you so much. I appreciate you stepping up and being here, and thank you for your public comment. Do we have anybody else live in Carson or Vegas, or that is virtual or on the phone, that is interested in speaking as part of public comment number 1 at this time? Crystal, as far as I can tell on the attendees virtually, I have no one with their hand up. Emma, can you give me confirmation that we're all good in Vegas?
Chair, this is Terry Kerns. I have a public comment. Just for knowledge of the group, I just wanted to highlight that this past week or the week before, the Office of National Drug Control Policy came out and endorsed a national non-fatal overdose database, and that is using NEMSIS or EMS data. So I just wanted to make everyone aware that that is moving forward and endorsed by the Office of National Drug Control Policy.
Thank you, Terry. Thank you for your public comment. I believe we are all clear on public comment number 1. I'll open it up one last time. If there is anybody available or interested in public comment, either in person in Carson City or Las Vegas, or virtually on Zoom, this is your final call. All right, I don't see any hands up. I'm going to move forward to agenda item number 3. So agenda item number 3 is welcome, and really a thank you for showing up today. Today we're going to be going over some objectives for our cross-sector task force to address the overdoses in Nevada. Again, Attorney General was unable to make it today because of illness, and I am chairing this meeting in his place. I just wanted to again thank everyone for being here, and also take a moment to acknowledge that we've made it here and we're working together to determine some necessary actions to reduce the risk of overdose in Nevada's communities. This task force is going to be presented with some suggested steps for making an action plan today, and we will hear from some informational presentations, and then we'll be coming up with an approving plan of action. Can we move to agenda item number 4, please? Oh, one thing that I left out on 3, sorry about that, is if we do get to a point where we will be making some decisions as a task force, as a group or committee, I am going to ask that the committee members please turn on their cameras so that we can acknowledge that we have quorum, so that we can acknowledge that we have the people that are part of the committee are actually here. If you have questions or comments, I'd just like to ask that we try to abstain from repeating the same things over and over, and also let's try to plan today to get some things done. is this the right slide? Because I was on, there we go. Agenda item number 4. We do have an action opportunity in this agenda item. We can discuss and vote to approve the minutes from our last meeting on November 2nd, 2022. Does anybody get a chance to look at the minutes? Does anybody have questions, comments, concerns? If not, can we get a motion to approve?
Approve. Debbie Nadler.
Thank you, Debbie. As committee members, I'd ask that you just unmute yourself and speak up if you have any questions, comments, or concerns. And same goes for making a motion or backing a motion.
Chair, this is Carissa Loper for the record. I will motion that we approve the minutes as is from November 2nd, 2022.
Thank you, Carissa. I did get a chance to go over the minutes and everything looked adequate to me. Do we have a second for Carissa's motion? Got, go ahead.
Lisa Lee for the record. I'll second that motion to approve the minutes from our November 2nd meeting.
Thank you, Lisa. Crystal, correct me if I'm wrong, but I believe at this time we're going to ask committee members to vote to approve, and we'll do that in the usual virtual manner. I'll ask all in favor, and then I'll ask all opposed, and then I'll ask all abstain. All right, all in favor to approve the minutes from our last meeting, November 2nd, 2022. Please identify yourself with an aye.
Aye.
Aye. Aye.
That always gets me because I just have a bunch of people yelling out aye. Any opposed to approving the minutes from our last meeting? And do we have any committee members that are going to abstain from voting on this action item? All right, looks like the motion to approve the minutes from our last meeting has passed, and we will have that added to this meeting's minutes. Can we move to agenda item number 5, please? Thank you. Oh, I did see a note in the messages, which I really would like to hear some feedback from, I don't know, oh wait, I do know. The presenter, Dr. Kadir, was mentioning that they have something to do at 1:45. So I wanted to see if it's possible for me to move agenda item number 6 up one and have Jamie Roscoe after Dr. Kadir so we can get that presentation done. Is that something I'm able to do? And do we have Dr. Kadir available?
You're allowed to do that.
Thank you, Henna. Dr. Kadir, are you able to give your presentation at this time so we can get it done before you have to leave? This is important that we get this one taken care of. I recognize that we had some issues with audio for Dr. Kadir as we were starting this meeting, and I haven't heard anything yet. Can I get Crystal or someone to help me verify if Dr. Kadir is here and is able to present? If not, that's fine.
He is here. He's listed as Lori, and let me find, I think are you guys able to, can we hear you yet? Are you still muted or muted again?
The last time I saw the participants list as panel or as attendees, I have Lori and Dr. Kadir on the phone, and it does not look muted. So they are currently attendees on my screen. It says total 1 phone call in listener. So maybe that's the issue. If that's the case. Oh.
Hi, can you hear us?
Yes, yes, we can. Do you have time to give us your presentation before you have to go?
Yes. So I'll start with, we are a small town. We have a population of around 1,200 to 1,600 at any given time. Out of that population, we have had 22 overdoses in non-fatal overdoses in the last 2 years. The deaths are unknown, but we think at least 3. Getting statistics is one of our biggest problems. We have had 9 suicides here, and in one way or another, they are related with opioids or addiction. Also, besides those suicides, we have recognized at least 45 children who were directly affected, and we have them as a suicide list that needs to be taken care of. So it's a huge impact. Our population, the tribe, is so little that we are rarer than the number of pandas in the world. So even one death is a huge loss for the community. Up here, we have had parents losing their children when it's supposed to be the other way around. It's not natural. Children losing their parents and nobody to take care of them. And I already talked about how small we are. The parents who use their children are neglected in both medical care as well as their routine care, nutrition, and everything. We have resulted broken attachments, broken relationship in adulthood, disconnect with the community, and our trends. So we had, we were at one point labeled as second highest prescribing tribe in Nevada, which was actually statistically wrong, and we gave them the correct statistics. But it did get us thinking, and we started a process where we started teaching our providers. I did get outside help to teach them as well. But this is something that we need on a regular basis. We still have a huge need for teaching for not just our providers, but our community as well. Part of the problem was the enforcing of our controlled substance policy because of COVID. We could not do any pill counts for about a 2-year period. We could not do, because of the limited number of patients that were allowed in the clinic. Drug testing was limited, but now it's all improving again with the education, with the pill counts, drug testing back on track, and we have acquired some lock boxes and locking pill bottles. So what we need, we obviously need some funding to help us with drug testing, because each test costs, not the screening test, but the test that we do with chromatic spectrography is over $200 in cost. And we also need some more staff. We also don't have, like, we couldn't get any statistics about how many patients we had seen, as we did not have anybody who could do that with our electronic health record system. We need staff education. We need education for MAT. We don't have a team that we can use as a team approach, which is the standard of care for pain management these days. We also do not have a team that can teach regular community members for CPR training and how to use Narcan. So we also are in need for testing for fentanyl test strips, because the fentanyl that's available to general public that they are getting from wherever else does not test when we do our regular screening tests up here. That's pretty much about it.
Great,
thank you for listening.
Yes, thank you for presenting, Dr. Kadir. I appreciate it. And, you know, you put tracking for statistical purposes. I know that that's one topic that we'll be covering here today, and it's definitely of interest to this committee. And that's, I'm glad that you brought education, staff education regarding opiates and medically assisted treatment. I just wanted to ask, do you guys have providers that are available to your community that can prescribe the buprenorphine to kind of help people?
Yes, so we had a provider who was here for a better portion of a year, and she was a lot of help. I'm working at a to get that MAT certificate as well. So I'll be able to do that in about a period of 2 months or so. But that's something that we are moving towards, definitely.
Okay. All right. Thank you again, Dr. Kadir, for presenting. Lori, thank you for supporting. Do we have any questions or comments or concerns for Dr. Kadir from the committee?
Yes, Chair, this is Elyse Monroy Marcella. I have a question for Dr. Kadir if he's still available.
Yes.
Thank you for your presentation, Dr. Kadir. I understand the limitations. Well, I'd like to know more about the limitations you have related to collecting data. So you mentioned that you have trouble pulling data from your EHR system. What other types of challenges do you have with data? Do you guys have, I'd just like to know more about the challenges, I guess, to better understand what the specific barriers to getting data are. Thank you.
So basically, we are about 100 miles each way from any town. So when we lose a professional, it's really hard for us to get anybody. So the only challenge that we actually have is somebody qualified enough to work within the EHR and get us data. So for example, if I wanted to see how many patients we have seen for diabetes this year, I wouldn't be able to do it today. I could do it a few months back, but since we lost that person, we have not had an application, even an application for that job. So if we don't have an application, we can't hire anybody. So basically, it's the manpower that we need in that respect.
Can I add to that?
Yes.
Can I add something to that? I think also our EMS and our coroner does not enter anything into our EHR. And so we're missing out on that information because it's not tracked in a way that can be accessible.
Does the tribe, and excuse me for not knowing this, does the tribe have its own EMS and its own coroner outside of the state system?
Yes.
What about their own vital record system?
I'm going to go with a no.
Okay. Okay. And I don't know if this is something you guys can put on the record on an open meeting. What kind of EHR does the tribe utilize at their clinic? Do you know your vendor?
RPMS, but we're switching to next gen in January.
Okay. Okay, thank you. I appreciate the additional context. I will say it's disheartening for me to hear that the challenge is people and bandwidth, but in a world that is increasingly more connected, maybe there's a way that somebody can help with people virtually to help data mine if that's the challenge. So thank you for the additional information.
Yes, and another layer to that is the grants, like all grants want statistics. And we're unable to really provide statistics because we don't have access to that information. One, it's not being tracked, or two, it can't be accessed. And so that really limits opportunities for grants and stuff too. So that's an additional layer to that.
Thank you.
Thank you.
Great questions, Elyse. Thank you for getting that clarification and kind of getting us a better perspective on what the struggle is like in Dr. Kadir's population. Debbie, I see your hand up.
Yes, just for the record, there is something, and I'm not sure who has access to it, but it is the only reliable mapping in our country. And I don't know if anybody's heard of it. It's called ODMAP. It's an overdose mapping tool that allows first responders to log an overdose in real time into a centralized database. And it allows, you can capture all the fatal and non-fatal overdose incidents on a shared data platform across agencies and across the country. So it's a real-time tool, and it's called ODMAP, as in Peter.
Thank you, Debbie. I think that there are some other committee members who have interest in looking into what that would look like to have that integrated into our tracking system, but I'm sure there's a lot more to it than I
can put the link, if you want me to put the link up in the chat, I can.
No, that's okay. People can Google it. It's pretty straightforward. During your share, I Googled it and it came right up, so.
Okay.
Thank you. I don't see anybody else for comment, question, or concern for Dr. Kadir. Again, I'd like to thank you, Dr. Kadir, for sticking around and giving your presentation. And also thank you, Lori, for backing up and supporting, getting us a good perspective into what it's like in rural tribal communities.
Thank you.
Thank you. At this time, I'll move to back to agenda item number 5, and I'd like to ask Jamie Ross for her presentation, or their presentation. Sorry.
Good afternoon. Can everyone hear me okay?
Yep, we got you.
Fabulous. Thank you so much for having me present. My name is Jamie Ross, and I coordinate the Nevada Statewide Coalition Partnership, serving coalitions serving all 17 counties in Nevada. Next slide, please. So this is a map of all of the coalitions who focus on substance misuse prevention in the entire state. If you notice, Partnership, what is now Partnership Carson City, was founded in 1989. So the coalition structure in Nevada has been around for more than 30 years. The Nevada Statewide Coalition Partnership was actually founded in 2001 and funded through the Bureau of Alcohol and Drug Abuse, which was called BETA, that turned into SAPTA, that turned into DWP, a bunch of other acronyms that is now DPBH. So this has been funded since 2001, and our coalitions have existed since 1989. So just a little bit of history. Next slide. I was asked to present on what's already happening in the world of prevention and to focus specifically on fentanyl. So here are some of the issues. As we know, community messaging is hugely important. There are large governmental entities that put out huge national media campaigns, especially around fentanyl. If you guys are familiar with the One Pill Can Kill campaign, what we know is that targeted populations, the subpopulations, really are where bang for our buck exists. So our youth teams. Our youth teams are often our eyes and our ears. Every coalition covering every county has some form of a youth team, which is where the information about what's actually happening in schools comes out. And that's oftentimes where we get our most recent information, obviously parents. On law enforcement is oftentimes where we're seeing the overdoses happen. And so getting that information out into the community. Our school staff, a lot of times what we know is best practices in prevention aren't necessarily always common sense. Scare tactics seem like a really great idea in theory, but what we know is scare tactics actually are not best practice when it comes to prevention. So really educating our school staff, working with our parks and recreation departments. Also nalox boxes. There's multiple funding streams that fund Narcan distribution where folks are using drugs that have safe CPR equipment, CPR masks, gloves, fentanyl test strips, Narcan, et cetera. Naloxone training, it's actually our coalitions in many parts of the state that are doing the majority of our naloxone or Narcan training. JTNN has trained most of the casinos in Narcan distribution, courts, Northern Nevada CARES, National Guard, housing and homelessness, distribution of fentanyl test strips. Now, obviously, the coalitions receive those from our dear partners at the state opioid response, as well as the overdose OD2A funds, but really getting those out into the community of people who use drugs and family members of people who use drugs. We oftentimes hear about fentanyl being a street drug problem. At our last pill take back day, we do 2 of those a year with the DEA. There was an entire box, like a paper box size of expired fentanyl, both liquid and patches that were turned in. So really safe disposal is hugely important. And then all of this being incorporated into our existing programs, especially when we're talking about primary prevention, which is ensuring folks don't do any dangerous behaviors, don't do drugs. It's less about talking about the drug, and it's more about adding risk and protective factors into existing programs. And then our most and our fast programs are really on the forefront of this and making sure that they are aware, because unfortunately, as this fentanyl epidemic continues, they are often the first responders. Next slide. So here is some of the media campaigns. This is just an absolute snapshot of some of the media campaigns that have been done. In the top left, it is there was a fentanyl PSA that was done by the DEA, and then it was translated into Spanish by one of our partners. You have on the top right information. Unfortunately, in Battle Mountain, Nevada, there was a group of youth who had purchased what they believed to be a vape cartridge that had been altered to be a THC cartridge, and unfortunately, preliminary results show that it had fentanyl in it, and there was multiple overdoses. So being involved in that post-overdose. On the bottom right, you'll see the Back to Life campaign that the PACT Coalition did, really focusing on increasing access to Narcan and increasing use of Narcan for our first responders. Next slide. Community readiness is the probably most important thing that our coalitions do. At the last one of these meetings, Dr. Woodard spoke on ready, willing, and able. If we have the most pressing problem, but we have no understanding from the community that it is a problem or no belief that it is a problem, then that is where we focus on, is really community readiness. Naloxone in schools. With the Narcan in schools bill that passed in the last legislative session, most school districts have added that in, but there is one county that is my understanding that still does not have Narcan available in schools, and our coalition is working closely with that school district to encourage and to support and to advocate in the ways that they're able to. Also, youth overdoses. As we've seen youth overdoses rise, we've seen community readiness really rise when it comes to this, because any overdose is sad and tragic, but overdoses with our youth, and we are seeing a lot of our overdoses in our middle school populations. And then the subpopulations that are most at risk are Latinx, Latine, Hispanic, our LGBT populations. Those are areas that are hit very hard by this. Next slide. So talking about some of the unique collaborations that we've been able to focus on in some of our communities, partnership, Carson City specifically, their coalition staff are the ones who train school nurses, hospitals, and police. That is where all of the Narcan distribution happens throughout all of Carson City. Partnership Douglas County actually created the utilizing the overdose map project that Dr. Terry Kerns has been instrumental in bringing to Nevada, and then that Debbie mentioned just moments ago, utilizing that, creating a spike plan from the overdose OD maps. And that was actually utilized, for those of you who may not have heard, not too long ago, there was a an issue up in Tahoe where multiple law enforcement officers came into contact with what they believed to be fentanyl, and there were 30 doses of Narcan that were utilized. So we'll continue to monitor that. But that spike plan was used through that. Joined Together Northern Nevada in Washoe really focuses on ACEs mitigation and is encouraging their schools and working with their schools to integrate that throughout the community. Our community health worker program really is often where Narcan, naloxone distribution, and fentanyl test strip distribution is happening in our communities, especially to family members. And then our coalitions are often the ones providing the Narcan naloxone in schools and working on harm reduction strategies. Again, going back to community readiness that we spoke about. We also have the Handle with Care program that mitigates childhood trauma that Joined Together Northern Nevada is working with the school district as well as Washoe County School District Police Department and Big Brothers Big Sisters. So next slide. So emergent needs. One of the things that we have seen is there seems to be a nationwide shortage of naloxone. So making sure to get that into the hands of the people who most need it. Fentanyl test strip right now, there is a significant supply, but of course, just like everything, all of these funds are grant funds. So as the grants go away, then so do the funds to pay for these things. Additional law enforcement training and equipment, such as what happened in Douglas, and awareness of amphetamines mixed with opioids. That continues to be a huge issue according to our first responders and those who work in harm reduction. And then our community request. One of the things that we see oftentimes when there's a big influx of funding is we need to fund new programs. There are programs that have been in existence in pilot phases for years and years that have great track records of success that are able to grow into larger programs with additional funding. So really growing the existing programs that have already been vetted and work in Nevada, and supporting for secondary and tertiary prevention. Secondary and tertiary prevention being the things after primary prevention and before and during harm reduction and access to treatment. And unsurprisingly, the majority of the funding coming for prevention really does focus on primary prevention, which is completely understandable, but there is this gap where folks who are young folks, adults, et cetera, there's just not nearly enough funding. There's not enough funding for anything, but that is definitely an area where there is significant need. Next slide. Opioid solutions, schools and youth, really increasing ACEs, adverse childhood experiences, or prevention of adverse childhood experiences, which is PACEs, evidence-based programs in schools. One of the things that we know is that is a great place to target our youth, but we also know that if we ask our teachers to do one more thing, it will be a significant problem, even more so than we're already having with our schools. So collaboration with prevention specialists, those who are expert in how to deliver evidence-based prevention programming. And there's actually a pilot project that will be starting up shortly utilizing the state opioid response dollars. But again, growing these and focusing on the school to behavioral health pipeline. So often there are screenings, there are all of these issues that we know that arise within school. And unfortunately, this information cannot get out directly into the public, or there's just not enough resources. And then an amazing program that one of our partners in Churchill worked on was mindfulness, and it has been so successful that it's been implemented in every school in Churchill County, which is Fallon. But unfortunately, again, it is growing programs to scale. And that is all of my presentation. Thank you so much. And if you have any questions, I'm open to that.
Great. Thank you so much, Jamie. That was really great and really well done. Thank you for putting that together and presenting for us. I'm going to ask now, are there any committee members who have questions, concerns, or comments for Jamie? And initially I have Debbie Nadler's hand up. Debbie?
Yes. Hey, Jamie, thank you so much. Great presentation. I wanted to let y'all know Narcan is not mandated in one school in the state of Nevada. It can be used. I've talked to CCS, Clark County School District. I've called different schools. I'm working with Senator Gansert. We had talked about it in the last meeting. I think Attorney General Ford told me that we needed somebody to back us to get it mandated. And Senator Gansert's going to present it in legislature to have it mandated in the schools. You can only do middle school and up, just for the record. So it's not being used. I've called around just the schools that my kids went to in Southwest in the Valley. Also, as far as I had an idea, as far as the students, it's being done in California right now in some of the counties. The back of our students' ID cards, they don't have hotline numbers. If we could get a QR code or a hotline number on the back of all the student ID cards, at least middle school and high school, that gives them a suicide hotline, a drug hotline. Because what I've found in California, just a cohort of mine, the parents are using it. They're the kids' IDs to get help and call. So it's not only helpful for the kids, but for the parents as well. I'm not sure if that's something we need to bring before legislature, if that's something we can do. I'm not sure. I just think it is a great idea for our kids to have this access.
Thank you, Debbie.
Thank
I
you.
appreciate that.
Jamie Ross for the record.
Go ahead,
I think to address your issue with Narcan in schools. So yes, right now, the way that the law reads is may not shall, but I do know that every school within Clark County School District does have access to Narcan. And again, that's middle schools and high schools, you are correct. That is stored in the nurse's office, as well as Clark County School District police have access to it as well. And that is specific to Clark County. It is not currently, to my knowledge, available with teachers, but it is available on school campus in those two instances. So I think that's interesting that Senator Gansert is interested in changing that may to shall. So definitely would like to connect with you offline about that. And then as far as the QR code, I am surely not an expert as far as how a bill becomes a law, but I believe that if the school district wanted to, they wouldn't need, if this were to be mandated that every school required this, then obviously that would need to be a law. But if each school district wanted to do something like that, that is something that they could do, I believe, without changing the law. But again, I am not an expert.
Thank you. I don't know who could help me do this, but if we can all kind of somehow do it. And I know it's working in some counties in California.
Thank you. Thank you for your comment, Debbie, and thank you for your response, Jamie. I have Elyse Monroy Marsala next.
Thank you, Chair. Hi, Jamie. So two questions. Well, first a comment, then a question. So looking at the data, we know that there's been a growing impact on fatal and non-fatal overdose in that age of like 18 to 24, which gets squirrely, right? When we are really focused on school-based interventions or initiatives. So I'm wondering if there are coalitions in Nevada that have partnerships with universities or trade schools to do education. And then if you guys are currently working at all with the Recovery Friendly Workplace Initiative as another way to kind of get target this population that is being impacted by overdose but isn't in a school.
Thank you, Elyse. Jamie Ross for the record. And yes, I wholeheartedly agree with you. And that's why when we're talking about secondary and tertiary prevention, there really just is such a lack of funding available to target those specific subpopulations. So as far as our coalitions working with the universities and trade schools, yes. the coalitions are to the best of their ability. Some as with all things, things are going really, really well, and then a couple of key staff leave, and it takes another 6 months to a year to rebuild relationships. But that is something that is happening. And as far as recovery-friendly workplace, I know that many of the coalitions are working, but it is definitely an area that I think we would all be interested in strengthening the recovery-friendly workplace collaboration, because it is such a key focus for especially helping our young folk who are already struggling to find employment.
Elyse, can I just add also, this is Terry Kerns for the record, under the OD MAP grant that we have, UNR did participate, and it was more of an education campaign targeting the students on campus. And I know they did a lot. They did social media, they did posters, they did flyers, and it was a bilingual campaign that they did. And again, just focused at UNR.
Excellent. Thank you.
Great. Thank you for your comments, questions, and responses. Lisa, you have the floor.
Thank you, Chair Sanchez. This is Lisa Lee for the record. I just wanted to respond to Debbie's comments. I'm holding my kid's student ID in my hands, and there is Safe Voice. Safe Voice was something that was established by SB 212, I believe, in 2017. It is a hotline. I know my own 16-year-old has used it also. And I also just wanted to say, and again, this is the Washoe County School District student ID card. It says Safe Voice. It has the 800 number, the text number, the website. It says report safety concerns live 24/7, 365. It also has a national suicide prevention lifeline, 988, or text care to 839-863. So I just wanted to say that currently, at least in Washoe County, that is a practice that has been adopted since the passage of that bill in 2017. Thank you.
Great. Thank you, Lisa. I have Debbie with her hand up.
Yeah. Hey, Lisa, thank you so much. If you could do me a favor after the meeting, just message me that information, because in Clark County, I know in the middle schools, they don't. I've reached out to several different ones. I'm not sure if it's a high school thing or middle school, but if you could send me some information or collaborate with me somehow in getting it done down here, if you don't mind, that's great.
And I think we've got one more question down here as well.
Giuseppe Mandel for the record. Quick question for you, because I've heard a couple of things. I know I'm not a member of this committee or this board, or that we're not, but we're with Tinhai and Alternative Peer Group Las Vegas. Kind of some of the things you were mentioning, the Alternative Peer Groups is a national program, evidence-based. We do have one here in Las Vegas, and it is 13 to 24. So it's not just high schools or education. We're open to, obviously, an invitation to this board, because we are we have a lot of the services that you guys are requesting, and anything that we can do to be of service, we'd be happy to. And we'd show up to all these meetings as well. And as far as the recovery friendly workplace, I am also on the advisory board for the recovery friendly workplace. So I think Jamie Ross is doing a great job with collaborating with myself, at least, because I am on the advisory board for it, and with the youth. So I'm always open to questions, and I mean, you can get a hold of me through Jamie or at There's No Hero in Heroines Alternative Peer Group with myself and Yohey. Thank you.
Great, I appreciate that. Thank you for your comment and bringing that forward into light to us. It's good to know that we have a solid group of people committed to this. At this time, if there are no more questions or comments for Jamie's presentation, I'd like to move on to agenda item number 7. All right, I'm not seeing anything in the chat. Did we have Dr. Woodard here today, Dawn?
No, Dr. Woodard's not here today, so I'm going to be giving the presentation on the state plan.
Yeah.
Dawn Yohey, for the record, I'm the clinical program planner for the Fund for Resilient Nevada. And if my presentation works, this is a little bit of information on the Nevada Opioid Needs Assessment and statewide plan, which was just completed in December and is currently live on the website. So a little bit of history. In 2021, Nevada passed Senate Bill SB 390, which is codified in the Nevada Revised Statutes 433.712 through 433.744, establishing the Fund for Resilient Nevada. One of the Department of Health and Human Services responsibilities was the development of a statewide needs assessment and a statewide plan to identify implementation priorities related to addressing opioid-related harms using a data-driven and evidence-based approach. The needs assessment was completed at the end of July, and as we were developing the state plan, we were noticing that we were copying and pasting a lot of what was in the needs assessment into the state plan. So in order to consolidate it and to make it a more robust document, we put them together. And so what you will see is the Nevada needs assessment and state plan all in one document so that you have all of the information there and you're not toggling back and forth through several documents. So section 1, you will see an executive summary. In section 2, you'll have an introduction. Section 3 is the methodology. Section 4 is the opioid impact in Nevada. Section 5 is the current system addressing opioids in Nevada. Section 6 are all of the recommendations. And section 7 is the statewide plan, and section 8 is next steps. So a little bit of the breakdown of the sections. Sections 6 through 3 comprise the needs assessment. 4 through 5 present the opioid impact and currently available systems, as well as corresponding gaps. The gaps identified in sections 4 and 5 informed each of the recommendations in section 6, and then section 7 provides the statewide plan with goals, strategies, objectives, and activities developed from the recommendations and stakeholder feedback that may be funded through the Fund for Resilient Nevada, as well as other funding sources. And then section 8 offers details on the next steps for further detailing the activities in the statewide plan and a preliminary allocation proposal. Some of the appendices breakdowns. A is data sources, B is a reference document, C is prior work towards Johns Hopkins best practice recommendations, D is any additional data that we had to use, E is the approved uses for opioid recommendations, and then F is our policies and procedures. This is the proposed budget recommendation for the statewide plan and goals. None of this has been approved through IFC yet. We were going to be going tomorrow or on Thursday to IFC, but some things came up and we had to push our work program to January. So we will be asking for approval and use of the fund in January. But here's a preliminary budget for everybody to see. And this is actually what you'll see in the statewide plan as well. All of these numbers can change, but based on the needs assessment and the recommendations, these are the goals that you will see in the state plan. So goal 1 is to ensure local programs have the capacity to implement recommendations effectively and sustainably. Here are some proposed funding estimates for FY 23, 24, and 25. And then you have goal 2 of preventing the misuse of opioids. Goal 3, reduce harm related to opioid use. Goal 4 is provide behavioral health treatment. Goal 6, implement recovery communities across Nevada. Or goal 5, goal 6, provide opioid prevention and treatment consistently across the criminal justice and public safety systems. And goal 7, provide high quality and robust data and accessible timely reporting. So like I said, we don't have approval to use the funds in this manner yet, but we will be going to Interim Finance Committee in January in hopes to use this. And within the plan, you will see the breakdown more of what goes into all of these goals. So what actually does it mean to ensure local programs have capacity to implement recommendations effectively and sustainably? You will have those goals, the strategies, objectives, and activities. Dr. Wagner, did you have a question?
I do. Thank you, Don. Carla Wagner for the record. I'm just looking at these numbers and wondering how these budget figures were set. And I'm specifically looking at goal 3, reduce harms related to opioid use. So $140,000 a year towards harm reduction, where in other categories, there's $500,000, $1 million, $1.5 million per year. So why are we underfunding harm reduction to that degree in this budget?
And like I said, these numbers are not set in stone, but based on what recommendations fell under goal 3, harm reduction related to opioid use, we're really trying to do, what we're trying to do is make sure local programs have the capacity to implement recommendations effectively and sustainably. And then we are also doing fund mapping. So some of the funds from our state opioid response grant, or maybe our OD2A grant, some of those funds are already funding a lot of these priorities. So, so we did have to take all of that into account too, so that we're not being, we're not supplanting any funds.
Totally get that. Thank you. Carla Wagner again. I just want to say for the record, we are a state with 2 needle exchange programs, and $140,000 a year is not even enough to stand up a single needle exchange. In places in Appalachia, there are hundreds of needle exchanges for small states. So this is kind of, I would really like to see all the math on where all the other money is going to come from, but this is a dramatic disparity in my opinion. And I understand that there's more that went into it than that, but I think it would be really great if we could see it all.
Yeah, no problem. We can hopefully get some of that a little bit more detailed to you guys shortly.
I have Debbie, and then I think Elyse, and then Dr. Kamiar.
Hi, thank you so much for the presentation. Is there perhaps a link you can share with us for the state plan?
Yeah.
So we can all see it, if you don't mind sharing.
Yeah, it's right here.
Okay.
So here's the link to the state plan. And
perfect.
we will go ahead and send that out to everybody as well, just so that you have it.
Thank you very much.
Mm-hmm.
Elyse.
Thank you, Chair. So Elyse Monroy Marsala for the record. So I just want to echo and I back up, honestly, Dr. Wagner in this. I would like to see if we could some sort of, well, one, the fund map. I have been barking about getting some funding transparent, like a fund map transparency since we started this work, but we were always told that was not our concern and not something we should worry about by other ACRN staff. So I really would like to see a full map of where all the state's funding, opioid funding is going. So we can have a more accurate picture. I also, if we could see how the funding amounts were allocated, like the process for, you know, the score, everything, you know, every recommendation was like scored and weighted. Like, was that then used to to make the dollar amount determinations? And, you know, for what it's worth, and this is probably a lot more direct than I should be at this point, but for goal 7, there's about $2-ish million that was proposed for improving data. I work on the state's data collection services. I don't or on our state's opioid data collection. I have no clue what these dollar amounts would go towards. So I do think there needs to be a lot more transparency as to where this money is coming from. And then also a specific question. So I saw the last IFC agenda. It actually looked like there were 2 ACRN budget. So there was like a big one and then like a less bigger one. Is this money that's included on this slide from what's being proposed from the $4 million that was pulled? Is that what this is?
Yeah.
Okay.
Yeah, it is.
Okay,
but that we're pulling out of reserve to use for programming at this time.
Okay, perfect. And then that other one looked like it was a smaller amount for like staff or something?
Yeah.
Okay. Correct. Okay, perfect. So yeah, additional transparency would be helpful. I will just say I was really frustrated when Sheila always pushed back and said, we can't ask about funding, we can't ask about mapping, when it's a really important part of making a determination as to where the money is going. And to Dr. Wagner's point, we have 2 needle exchanges in the state of Nevada, and they're not even all running mobile outreach services weekly. Like it's our harm reduction, if we're just looking at needle exchange in Nevada, is woefully under-resourced. And again, I know that it is important that we talk about school-based interventions and youth interventions, but adults are dying by overdose at an alarming rate. And I think that we have a responsibility to talk about any and every death. And I will just say for the record again, the deaths that happened, the spike event that happened in Las Vegas that precipitated this joint task force were not youth deaths. They were adults that died. And I know it feels a lot easier to care about youth that are dying, but we have to care about all people that are dying, and ensuring that there is a multi-pronged approach to these interventions is so important. And I expect to see that harm reduction services we can bump this up a lot, because people, adult men, adult women, adult people are dying, and we need to improve services for those people as well. Thank you. I'll off my soapbox now. Thank you.
Yeah, and you know, this is just a draft, and it is just for the next few years. We're taking this slowly. We're making sure that we're making the right decisions. We're making sure things can be sustainable. So we're not going to come in and lift something right away that we can't sustain in the future. So I'm hearing everything that you guys are saying about harm reduction and data. We also need to think about making sure we have the capacity statewide and that we have the sustainability as well. So I appreciate it. Thanks, Elyse.
Yeah, thanks, Dawn, for responding, and thanks, Elyse, for your comments. Dr. Kamiar, and then Lisa Lee, and then, yeah, go ahead, Dr. Kamiar.
Hey, Farzad Kamiar here. Dawn, I guess a few questions for you. Do you have any insight into, Section 6, which was like the recommendations, and I'm just more familiar with the ACRN recommendations that we came up with. Do they map one-to-one with all the activities or in the goals section, or so 7, the state plan?
Yeah, as many as we could map to each of these goals.
So would there be ones that are left out?
Potentially. There could be ones that are left out that we're going to have to come back to at a later date. This statewide plan is ever evolving. So just because it's published doesn't mean it's completely done. Yes, it is done, but we come back to it every 4 years. We have to in statute. And so as things start progressing and moving, this state plan will continuously also be kind of like a live document. So
do you have any idea what process was used to go from section 6 to section 7?
Yes, I do. So we use the National Council, National Policy for Drug Control, and we took their goals, and then we took the recommendations and everything that we could figure out was a strategy. We could make it into a strategy, and then we filled it in with the objective. And if you look in the state plan, everything is ranked too. So everything that has already been ranked and everything that we could move over from all of those recommendations is in there. I would recommend maybe taking a look at it, and then if you want to, you can email me and I can walk you through that a little bit more.
Yeah, I mean, I guess one of the first things I had noticed when I just took a look at this plan was I think some of the items which previously had brought up that maybe from a legislative target had a score of 0, continue to have a score of 0. Yeah. And I thought that they would have been updated, because then if that score actually determines via priority ranking what goes in versus what goes out, that could have an effect.
And you know, some of the feedback that I got was, if it was a recommendation, it was probably a priority within the legislation, and there was only so many things at this time that could be given that extra target goal. But let me go back and find a little bit more information for you and send that to you.
Okay, thank you.
Lisa?
Thank you, Don. Lisa Lee for the record. I just wanted to elevate what Dr. Wagner and what Elyse, Monroy, Marsala, it feels so good to say that, by the way, Elyse, we're saying. And really, I find the amount of funding for goal 3 absolutely offensive to all the people. I've lost track of all the people in my life, friends and family, who are not here. And I don't think we'd need such an elevated goal 7 budget for data if my friends and family would stop showing up in the data. And so we have real actual deaths. We have over 107,000 people that will not be sitting around their family tables this year. That's beyond the SoFi Stadium, the amount of people, a whole stadium full of people that their families will never see again. And so when I think about reducing harm related to opioid use, I do think beyond syringe services programs. As we know, most people are moving from injection drug use to smoking. So we need to talk about safe smoking supplies, because there's been that shift. And we also need to talk about the harms that are caused to families, right? Child welfare involvement, where we see substance use, parental substance use as a factor for removal into foster placement. We need to talk about those harms as well. And frankly, $140,000 across the state is just, it's mind-boggling when you think about the actual impact of substance use and opioids across our state. So just wanted to mention that. Thank you.
Thanks, Lisa. Debbie?
Yes, hi. Thank you so much. So I don't know if this is where I would ask the question, but on the proposed budget allocation for statewide plan goals, I see all the dollar amounts, and I have to say, as much as for prevention and everything else, just three people in the past week were kicked out of rehab, out of detox, because they didn't have the money. They couldn't get MAT because Medicare under Moderna, I think it's called, well, whatever's not Blue Cross on Medicaid will not pay for MAT. And if that's part of the goal 3, then I'm going to tell you, 3 kids are out on the street that are going to die this week because they couldn't get the help. And that's just 3 kids I talked to. So yeah, if that has to do with MAT, that number is just so low. But in this proposed budget allocation, is the budget for Mercer, what we're paying them and what we're paying the attorneys, going to show in the budget allocation too? because I don't even know what we paid Mercer to do whatever it is that they did, quite honestly. Is that in the budget allocation too? Shouldn't that be transparent, what we're paying the attorneys and Mercer? And
I guess we could add it in there. No, I didn't add it in here at this time because these were just the statewide plan goals, and they were just a contractor that helped us.
But I think it would be important for us to see the percentage, you know, what we're paying the attorneys and what we're paying Mercer too. That's just my opinion.
Yeah, and I think the Attorney General's office has given presentations on how much has been taken out for attorney fees. So let me grab some of those and see if that's the case, and we can get those over to you.
That'd be great. Thank you so much.
Thanks, Debbie, and thanks, Dawn. I don't know how much you have left.
Just a few more slides. So you can find the needs assessment here. And then some of our next steps, we are doing a January interim finance committee to move funds out of reserve, like we had talked about. There will be a request for a proposal with Nevada State Purchasing to be able to do some of that goal 1. And then we are continuing to map opioid funding throughout the state, as well as projects throughout the state, which Elyse was just talking about. Now was the time for questions, but I hope I answered everything for you. And if anybody has anything else, please feel free to send an email over.
Yes, thank you so much, Dawn. And what I'm hearing is that it sounds like the committee thus far is looking for transparency, a bunch more open availability to information about what has been spent and how it will be spent in the future. I appreciate that there was a lot of comments on the proposed budget, but again, it is a proposed budget. So I believe there is room for that to change and be directed specifically by this committee, or at least the 2 committees separately. Does that sound accurate, Dawn? Do we have a say in what the proposed current proposal is, or is that just the way that it is right now?
That's how it is right now, and it's proposed because it hasn't been approved by any legislative bodies.
Now, does the SURG, ACRN, or this work task force have any opportunity to address or adjust any of those proposed budgets before they are approved, or are they moving forward without us?
No, that's in the director's office. But what we can do is take some more of your recommendations and bring that back. Good.
Because I think that's what we're going to get, and I think that's what we're hearing here is that with eyes on the proposed budget, we're having some issues as the committees that are meant to drive the spending of funds from the opioid litigation funds. So if there is an opportunity or a way to get each one of the committees and the task force a direct line to affect the proposed budget before they are approved, I would ask that an email gets sent out to committee members so that we can either schedule another meeting or present individual arguments, perspectives, whatever it may be. But it seems like that's going to be something that is causing some conflict. Elyse, go ahead.
Thanks, Chair. I guess I have a process question, and it's probably too late for me to be asking this question without sounding like I'm dumb or I've been asleep at the wheel. But if what's proposed on the PowerPoints is what is proposed and going to IFC, what are we doing here? Like, what are we voting for here? What is the objective of like what we're doing now? What are we doing?
So Elyse, this is just an informational item for you guys. What we have also done is we have tried to put in an allocation of money specifically to address overdoses And Dr. Kerns is going to be working that up in the next couple of slides, in which you're going to be doing a, I guess a plan, to an action plan, in order to address that. And then therefore there will be an allocated amount in that area for things to move a little bit quicker, funding to move a little bit quicker.
Okay, so so that is helpful. Okay, so but the allocated amount, that's what is coming out of what's going to IFC, or is that a different allocated amount?
It will also be going to IFC.
Also going to IFC. Okay. Okay, so we are going to be considering a plan and voting on a plan that has money tied to it today. Okay, excellent. Thank you.
Thank you for your clarification, Elyse. I'm glad to see that, or hopefully that clarifies things for you, but not just you, the whole of the committee or the task force. I was kind of leaning that direction, and I'm glad that I was, like, that means I was sort of close to where we're going. But at the same time, I foresee a lot of discussion and probably another meeting before any vote is taken. Let's move to agenda item number 8, and we will have Terry Kerns present the possible plan.
Thank you, Chair. First of all, I'd like to say that Dr. Woodard and I were supposed to be presenting this, and Dr. Woodard apologizes for not being able to be here today. So I will do my best to work through this with you all. I will say we have just about an hour and 20 minutes left, and there's no way that we're going to get through all of this and come out with an actionable task force action plan today. So Dr. Woodard and I spoke, and we're going to change what we had proposed a little bit from what's originally on these slides. And I'll go through first the expectations, and then we'll talk about what we're going to do. Next slide, please. The expectations for today, and looking at these task force action plans, are to use a consensus model for decision making, which is typically what we have been doing throughout the SURG and the ACRN. The action plan that we're going to be working on will leverage existing resources to the greatest degree possible and include existing federal funding. So we're not looking at using the funding that we just talked about. We're looking at existing programs and think strategically to develop actions at the state level. The activities must be evidence-based and demonstrate effectiveness. This as well includes messaging. So thank you, Jamie, for cluing up a lot of what you talked about already on the messaging. And then consider the implementation science, which again, Jamie talked about and Dr. Woodard talked about at our last meeting about the ready, willing, and able, because we have seen programs that we've taken into communities where we thought they were ready, willing, and able, and found out, unfortunately, that one of those pieces may have been missing. We want to focus on health equities and address disparities, and really balance that need for urgent action with planning. Next slide. In operationalizing these recommendations that we came up with, we want to establish situational awareness with data and current activities that are going on. Set the foundation for continued planning based on the Nevada Opioid Needs Assessment and State Plan. Work on accomplishing both the Advisory Committee for Resilient Nevada, the ACRN, and the Substance Use Response Working Group, the SURG. And we want to really move from general recommendations going into detailed action plans. Next slide. And this next slide kind of just gives you a template of what we're looking for as we look at operationalizing the recommendations. And what I will say on this section, we're not going to go through and try to work through all of these today. That will never work in this hour and 20 minutes we have. But rather, as members of this cross-sector task force and members of the ACRN and the SURG, which you are the subject matter experts, we're going to assign these out, hopefully through volunteering, as opposed to assigning to task force members to go forth and do homework to make these recommendations and help operationalizing them by developing them into action plans. And it's really by drafting a plan. It doesn't mean that if you agree or volunteer to work on operationalizing these recommendations that you or your agency becomes the lead agency. It's really to come back with that plan. And the idea that Dr. Woodard and I discussed is something that can be accomplished in 6 months. So something that's more immediate as opposed to years-long plans. One other caveat that we talked about is if you do agree to take one of these and work on drafting the plan for it, you can reach out to others to get information, but be cognizant of not getting in an issue where you're getting into an issue with quorum by having meetings and those sorts of things. If you have questions, our DAGs are always available for those questions. There will be no subcommittees, so this will all be homework that we hope that you will work on. And we do hope to have a meeting at either the end of January or February to discuss these. So what we did, Dr. Woodard and I went through one example. Actually, we'll go through this first. I'm sorry, go back. Go back to the slide. There's an example is what is the recommendation? Who would probably be the lead agency? What are the actions? Determine the readiness to implement those actions. Identify the existing resources, gathering additional data, convening stakeholders, endorse an existing plan, recommend a funding priority to state or local jurisdictions, and then accountability. That becomes the who, what, and when. What are risks of the plan or risk of not taking the plan forward, and what are facilitators? Next slide, please. So what we did is we looked at one plan that has already been put in place with a recommendation, and this was connecting public safety and local overdose spike monitoring agencies. The lead agency on doing this was the Office of the Attorney General. And what we're really talking about here were those community overdose spike response plans, which Jamie Ross referred to already, that Partnership Douglas County has used. So what we did is when we started putting those in places, we educated on the use of OD maps to drive local actions, identified the local overdose spike monitoring agencies. Somebody, can you mute your phone or camera? And then we defined who are the partners. We have public safety partners. We defined the public health partners, and then the community partners as well. And I will tell you that when we originally did this, this was probably about 4 years ago that we did this. We went to each county. We did not tell the counties who all of these partners were. We let the counties decide who those partners were. So it looks different in each county. I will tell you that the community overdose spike plan in Washoe County, the sheriff's office stepped up and was the lead agency. Here in Clark County, the lead agency was the Southern Nevada Health District. In all of our other counties, it was the community coalitions that stood up and became the lead partners, the lead agencies in those. So it does look, and even in where the community coalitions were the partners, it looks different in each of the counties because the counties are different. And the stakeholders that came to those meetings, it typically was fire, EMS, law enforcement, public health. Oftentimes we had the DA there, we had county commissioners there, the coalition partners were there, but it was really, we had tribal partners at some of the meetings. They were always invited, but it really looked different for each of the counties. So those all took place. Every county, as I've mentioned in previous SURG meetings, does have a community overdose spike response plan. However, in this is COVID hit, and those plans kind of got put up on the shelves and gathered dust. Some of the counties have taken them off and started looking at them again. Washoe has been very active in trying to operationalize their plan again. And as you heard, Douglas has used their plan. So they are plans, but we need to do some more work. So Dr. Woodard and I have started some work, but that's the operationalizing this plan. How can we get this statewide? So those are going to become the what, when, the risk. The risk are what happens if a spike occurs and a community is not ready. I will say one part, each of the plans does discuss communications, but I don't think it's really in depth enough on the communication. Who's going to be the lead agency on communicating if we did have a spike? Is it going to be public health? Is it going to be law enforcement? Is it going to be both of them? What's the combined message going to be? Those sorts of things. So we have a lot of these pieces in place, but we need now to move these forward. So that's going to be something that myself with the lead agencies from each of the communities are going to start to try to work on again to operationalize this recommendation. So the next one, moving on, this is where you all get to start raising your hands, hopefully, is the development of communications, which I told you is a big part of what we need. This was one of the recommendations of priority score number 14 from the plan. Identify substances involved in overdoses quickly. So this is something we've heard about even separately in our meetings, but in our last meeting, that we don't really have a way to identify the substances involved in overdoses quickly. Do we have a joint task force member that would like to be the lead on trying to operationalize this recommendation?
Thank you, Terry. And before I call on Lisa Lee and before I call on Elyse, looking over this, what I have as the document sent out on November 2nd, the cross-sector task force action plan, and I have these bullet points. What I found is that there's a lot of work that needs to be done on, I guess, the action plan, but number one of itself, identifying substances involved in overdoses. I'm not sure that that is necessarily something that this task force wants to pursue. So I think rather than someone raising their hand and working on something that the task force is not necessarily interested in, we ought to identify what we are interested in. And that would, and then, you know, as we go down to connect public safety and local overdose spike monitoring agencies. Well, connecting monitoring agencies, that's one of our major tasks, but it has 15 steps involved in it to get it to be functional. And so it's not simply titled Connect Public Safety and Local Overdose Spike Monitoring Agencies. It's something of a whole new nature, you know, and that, again, I think ought to be defined and guided by the task force itself through conversation and deliberation. We could keep going down through the final one here, but I believe there's another couple pages with some other ones. And now I will take Elyse Monroy.
Thanks, Chair. So I was actually agree that I think we should prioritize which of these kind of areas to look at. I think that we have to prioritize harm reduction and addressing harms. But that being said, if the committee does want to go kind of like in this list fashion, the OD2A program, which I work on, is already working to do the identification of substances. We're working with the State Public Health Lab to buy a mass spectrometer. So I'm happy to lead on that. But I agree with you, Chair, that I think that there are as important as I can't believe I'm saying this, given everything I've done for the last 4 years, as important as identifying substances involved are, we have to address the fact that people are dying at really high rates. So I think that we have to prioritize work on harm reduction.
Thank you so much, Elyse. And yeah, that's where I would, so I filled this thing with notes, this document that we got last month, and I hope that some of the other members were also able to, and not in a way of critiquing or anything, but just in a way that it would be best used as a tool by this committee, and my 2 cents on, as a subject matter expert. So thank you for putting that out there, Elyse. And I know that was a big thing for you to put that out there, but I'm glad you're listening to whatever it is that guides you to say that, because I think we're going to find a lot of commonality within the committee members of this task force. Lisa?
Thank you, Chair Sanchez. Lisa Lee for the record. I also have a whole bunch of notes and peer-reviewed journal articles for evidence. But I just wanted to say, here's my 2 cents on OD maps, that so far it has been insufficient. And I know that there have been a lot of barriers. So I recognize some very systemic barriers like the pandemic, right? But there's also this gate-kept access. There's been issues with poor input and data quality, and a lack of coordination with public health and harm reduction response or a publicly facing dashboard. Additionally, it misses all of the overdose that are reversed in the community where 911 is not called. We need an application where multiple types of overdose responders can enter data that has GIS capabilities and can trigger public alerts of bad batches, drilling down to neighborhood deployment of overdose education and naloxone distribution. I would also recommend that, just to stay on the topic of the development of communications piece of this, that the SURG Treatment and Recovery Subcommittee had a recommendation number 5, and I recommend that also be included in that recommendation. Gosh, I think we've changed it since I typed these notes up, but ensure that BIPOC communities are receiving overdose prevention recognition and reversal training and overdose prevention supplies such as fentanyl test strips and naloxone to reduce fatal overdoses among Black, Latinx, Hispanic individuals in Nevada, which is well supported in our data. This recommendation is derived from the state's overdose data that indicate racial and ethnic disparities, as well as on interviews conducted for the opioid use community needs assessment for Washoe County. Further messaging around protections of the Good Samaritan law, including any protections for undocumented individuals, needs to be communicated to Black and Brown communities, as there is historical trauma around police misuse of force, mass incarceration, and deportation. So I recommend that with any development of communication that we also think about that. Thank you.
Thank you, Lisa. Looking at how I'm going to need some support here, but that just trying to spitball some ideas of how our task force, which I'm not sure if everybody's aware, is a completely separate entity than the SURG group and the ACRN group. So we are 3 groups right now. We're the task force, which is its own group, and then some of us are part of another group, the SURG, and some of us are part of another group, the ACRN. That being said, it is the task force job to do what we're doing right now, Joint Committee Action Plan. It looks like to me, and this is just off the top of my head, Debbie, I will get to you. I'm not gonna skip over you, I promise. That in the name of efficiency, sort of what Dr. Woodard and Dr. Kerns were looking at is to get some stuff done. We ought to maybe take our 34 members, that's how many people, that's 18 on SURG, 16 on ACRN, and we can use this as a platform, right? We can use what is on there now, take it apart, put it back together the way we like it, and answer the questions that they're asking us to answer, but maybe as 3 separate groups of 10 people each or 11 people each. If that's a ridiculous idea, then I would appreciate any other suggestions. I'll call Debbie. What do you guys think on it? Debbie?
I like that idea. I just had one question, Dr. Kerns. For the identify substances involved in overdoses quickly, is that not something legislator can help us do? My partner got Tyler's law passed in California where they mandated all hospitals, anybody who came in, they had to test them for fentanyl. Is that something that would be part of that?
Well, and those are the kinds of things that we want that the group to come up with. Again, something that's not at this point a cost. At something within 6 months is what we're looking at. That's more of a legislative. That's probably going to be a longer term. But yeah, you're right. That's something that could be within that, but not for this immediate. But again, and we have talked about that, I know, as something I see definitely as a lack, that we don't have the capacity in most of our hospitals to test for fentanyl and fentanyl analogs, that they have the capacity, but most of the time they have to send it out to an outside lab and get results back in days, not hours. So that is something. But the task for here and looking at the three: development of communications, harm reduction, and access to care, is what we really want to focus on, and something that is really leveraging programs that are already in place, that's giving direction, where we can really put into effect something within 6 months.
Yes, that's awesome right there. Sorry, Debbie, go ahead.
No,
these were ones we came. I'm sorry. These were ones that we came up with, looking at the needs assessment and the state plan, looking statewide, not in one jurisdiction or another.
Yeah,
I would add that.
Yeah, that adds a lot of clarity for me, Dr. Kerns. So then it does sound like we're that might be a viable option. The whole split the 34 into 3 groups. One for development communications, one for harm reduction, and one for access to care and treatment. 11 persons each, and have them come up. Either take these apart, put them back together, or come up with what it is they would like to see done. So, we have an hour left right now. I would ask that this committee take I don't know if I'm allowed to, but I think I'm allowed to take a 5 or 10-minute break just to use the restroom or take a deep breath and then come back. I know it'll help me. And then when we get back together, we're going to finish up agenda item number 8. And really, we're going to roll right into agenda item number 9, a discussion for next steps. And that's when we're going to come up with a concrete, we agree as a committee, this is what we'd like to do. And I don't want to step completely away from what Dr. Woodard and Dr. Kerns want of us or suggesting of us, but I do want to come up with a way that the committee members feel that they have direct input and drive of the process itself. So let's take that quick, do an 8-minute break. We'll come back at 3:05. It is 2:57 right now. I'll see you all here at 8:05. No, sorry, not 8:05, 3:05. Thank you. All right, it is 3:05. We're getting down to the end of, or no, not to the end, but we're on our last leg of this meeting. Before we left, we were described a process by Dr. Kerns that was put together by Dr. Kerns and Dr. Woodard. And I had presented that the committee have an opportunity to kind of process and work together within the committee to find a way to bring forward an action plan that would reflect more directly what the committee, like through their expertise, would help, considering the three sections of development of communications, harm reduction, and access to care and treatment. I had pitched an idea of separating the 34 members into 3 separate groups that would tackle one of the 3 main areas of concern, and then bring back to the committee and to Dr. Woodard and Dr. Kerns what we came up with. And that is, of course, continuing to utilize the process that was presented as far as coming up with the main bullet point or main action, and then assigning or figuring out who the lead is as far as the task force, what the lead agency is in the state, what's currently being done, so on and so forth. Like I said, I had some time to go over this initial action plan, and some of the questions that I came up with were, what is the end goal of this action? How will this mitigate or remediate the harms of the opioid epidemic, or currently the overdoses, since we're looking at a 6-month timeline? And really, to answer something quickly, I also added, what are we already doing? Who needs to be involved? Who should be in charge? What equipment or technology is needed? And what needs to be done to make this happen? I can, yep. Okay. So I'm gonna open it up to Terry to jump in, and then I'm gonna get back to the committee, and we're gonna come up with a way to move forward. Terry?
Hi, thank you, Chair. I appreciate the opportunity. I just wanted to say just a couple of things, and I'll request the DAG on the line to weigh in if we need to. Is on your plan to have like 10 committee members come together. There won't be administrative support for this, so we have to be cognizant of not having a quorum. So if you have a lead, that lead person could kind of reach out separately to the people, but couldn't reach out to the whole group, so that we wouldn't get in issues with quorum. And like I said, there would be no administrative support. So it would be an issue of whoever the lead is kind of happen to coordinate all of the topics. Henna, are you on the call? Do you have any additional guidance on the whole quorum issue?
I do. I'm concerned. Did you say 10 committee members?
Yes, or really finding a way to use the 34 committee members as broken up. Go ahead.
That could, unfortunately, that could also be viewed as a subcommittee that's kind of being created. So you have to be really careful about that.
Okay.
And if it's a subcommittee, then you'd have to abide by open meeting law, and you'd have to have your meetings in accordance with open meeting law.
Dr. Wagner?
Hi, thank you, Carla Wagner, for the record. I don't know that if this is a question or for whom it is a question, but we've been in this meeting for 2 hours and 10 minutes and we haven't done any of this work. And I thought this was the whole reason for having this meeting. And I also thought this was the whole reason for having this meeting last time when we spent 4 hours in a meeting. So we get to this place where we've been on the phone for 2 hours and we haven't done the thing we're here to do. And now we're talking about breaking up into subcommittees that we can't have to go do the work as homework. Like, why can't we just use these meetings to do this work? I thought that was why we were here.
That's a really great point, Dr. Wagner. And I think a lot of us felt the frustration from our last meeting, being that this is a task force that was initiated to answer a response to an outbreak of overdoses. And now we're talking about a 6-month timeline, but in that 6-month timeline, we get to the point where we're supposed to be making decisions, and the decisions are presented to us in a way that are not actually guided or have our input in them, which is why we're stuck where we're at right now. So we have open meeting barriers. We have the task force being attached to the state as a barrier to getting together as smaller groups and getting something done. I'm looking for suggestions, ideas, past experiences that can help put our 34-person task force into a position to actually create our own action plan and then present it and get it done. Does anybody have anything to say on this? Lisa. Oh, Dr. Kerns wants in next.
Oh, sorry. Do
You're
you want me
good,
to
go
go
ahead.
after Dr. Kerns?
And whatever works for you, either way.
Dr. Kerns?
No, I was just going to say that was why we wanted to identify a separate task force leader for each one of these that would work on it. If you needed to reach out and get other information, you could individually reach out and get additional information, but then that avoided the whole, having a separate meeting. And I understand everyone's frustration, but we had presentations as kind of backup materials and educational materials before we went into this.
I appreciate that, Dr. Kerns. And that was brought up also before, is that the information that we've been given over the last 6 months seems to be very repetitive and also of our nature. We are the ones who created the information that you're giving back to us. We're the ones in the field that gathered the information, that gave it to the state, that allows the state to report it. So it just has really been feeling pretty awful as far as the time efficiency and the guidance given to the individual committees. So we're going to work through it. Nobody's to blame. We didn't lose anything. And what we need to do moving forward is come up with some plans, priorities, and processes that can get things done based off of this task force, 1, responsibility, and 2, expertise. Lisa?
Thank you, Chair. Excuse me. Thank you, Chair Sanchez. Lisa Lee for the record. I just wanted to also echo that it feels like we've been presentationed out. And really, I think we're all here to give input as subject matter experts in one way or another in some aspect of this plan. And it feels very paternalistic rather than participatory. And I'm wondering if there's an opportunity. I know in the SURG, SEI has been very, very helpful. And I just want to state that publicly. They've been very helpful with sending out surveys that we can add our input. And that's a way of data gathering. And then all of that data, all of our input is being reflected back to us rather than somebody else saying, here's what we're going to do. We're seeing our own pieces that we've added as submissions. And I just find that process really, really helpful, because I think we don't solve problems if we aren't working collaboratively. And so I was really hoping that this would be a collaborative process myself. And I'm wondering if we can use technological tools to accomplish this collaboration that wouldn't violate the open meeting law. It would allow us to share. It would be a shorter meeting because we wouldn't be raising our hands to share. It would already be presented back to us in collaboration. And I'm wondering if we could partner up in that way. Thank you.
Yeah, theoretically, that sounds awesome. Terry?
Yeah, can I just repeat what I think you're saying? So you're saying, for example, if we take development of communication, provide technical assistance, guidance, and resources, rapidly implement, that's pushed out, and then everybody provides their input on that, or each one of them is pushed out, and each committee member provides their input on each one of them?
Yes, if they have input, and it also just what we've been doing in the SURG committee, and I have found this very helpful. We have our justification, and then we also have our research links, so it's well supported with literature and evidence to support these recommendations and justifications. So if we could do something like that, so that everything that we're doing is based on evidence, I think that would be great.
And Carla Wagner, for the record, if I may just jump in there on, if we could use the questions that Chair Sanchez just read to us, and literally everybody could just run down the list and say what they know. We could, what is the goal? What are we already doing? What needs to be done? Like, he's got a set of questions. You can just poll the members on every one of these action items and do it that way.
Yeah, this is Carissa.
Let me, Las Vegas, you're, I see you and ready to speak. And I see, okay, so Jamie, I definitely see you. Jamie, I'm going to call on Carissa and then I'm going to call on you. Is that good for you?
Yep.
Thank you. Carissa.
Thank you, Chair. Carissa Loper for the record. I guess I want to ditto what Dr. Wagner said. So I think that would be a really good way. I was thinking, I don't think us going through this and asking, hey, is anybody going to be the lead for this right now, without giving people a minute to think through what it means to be the lead. So on that general survey of what do you know, how do you know it, what are you doing, if someone could say, I'm willing to lead this activity, or I'm willing to be the leader for gathering more information for this, or whatever we're actually being asked to do, that would be helpful to come from a facilitator through technology.
Awesome. Jamie.
Thank you. Jamie Ross for the record. I think if we can make this work with technology, I think that is definitely a great addition, but I would personally, I think Emma and SEI, they do an amazing job, but they are not the subject matter experts that all of us are. They are generalists and they're amazing at it. I would love to see if, and again, I agree with you, no one has to volunteer. We don't need to go in and divide, but there are a couple that I would very much like to have one of the humans who is the state subject matter expert on a lot of these things there to help guide the process, so it's not just SEI collecting data, but can weight the data in a way to ensure that, as a subject matter expert in evidence-based prevention programs, to ensure that if we're talking about prevention in schools, the solution isn't to bring back data. Because we know that DARE is not an evidence-based program. So I just want to make sure that we utilize our subject matter experts who would be willing to volunteer. And by no means are we voluntelling anyone or twisting anyone's arm, but I would really like to see if we could do a collaboration of both doing this via technology and then also ensuring that our subject matter experts, and also I think if only the folks on this committee are speaking, I think we're missing huge swaths of the population. That we need to make sure if we're going to do this, then it should be a more open process is my recommendation.
Great points, Jamie, thank you. So we have the idea of utilizing technology and surveys to find out how we can fill an action plan specifically on development of communications, harm reduction, and access to care. But we also need to consider that we would like to have public comment on them as we move through the process. And we have issues with assigning a lead or someone that can guide these actionable items as we move through. I'm honestly a little bit overwhelmed and kind of not sure which direction to go or what we're doing. So Dr. Wagner.
Carla Wagner for the record, may I propose that we can do all of these things? We can poll the members using the questions that you have to get all the information we have in this brain trust of 34 people. We can also, as Jamie suggests, have 1 or 2 subject matter experts in each point review those data and pull them up into a set of coherent things that can be presented at this meeting, so that then we can also have public comment and anybody else who's available weigh in if we've missed anything. We can do all of that.
That sounds awesome. Good way to clarify my brain for me. Thank you. Okay, so wait a second. Henna, are we good on, can 2 people, subject matter experts for each one, development of communication, harm reduction, and access to healthcare, can they work together, or is that somehow breaking the rules?
Are they on the committee?
Yeah, they're committee members.
So I'm trying to understand how the process is that you want to basically poll all of the members.
Yep.
So all the results of that poll, no one can really send them to each other. It'd have to go to one contact person that should be a staff member.
Yep, that will happen.
So then that staff member
gives the results of the prevention stuff to Jamie. Correct. Because she is the expert and she knows best. So she will go through and look at everything that everybody said, collate it into something that she can get her arms around, that she can present at a meeting, right? That synthesizes all of those data. She presents it at this meeting, and then that is what's subject to the conversation in the meeting.
And that's fine, so long as the poll that is taken and the results of that poll are not disclosed to anyone else on the committee but is collected by a specific staff member, and then the results of that poll would then be discussed at the next meeting. I think that should be fine. Is that where you're fine with that?
Can a committee member take the lead, because we don't want to saddle the staff with trying to figure out what's relevant to present at the meeting. We want a subject matter expert or 2 to take the lead on collating those results and turning them into something they bring back to the meeting.
Definitely a committee member can take the lead on that.
Okay.
But not speak with anyone else. 2 is pushing it, but yeah, it is less than a quorum. Arguably it is. I just don't want it to, it's all about perception, right? It's not like a direct violation at all. It's just more about perception and whatnot. And so that's kind of what I'm trying to protect you from. 2, you still should be fine. It's a very large group of people. And I think you should be fine in that respect. But those 2 should definitely not speak with anyone else on the committee, on the task force, I should say.
Jamie, does that pull in the expertise in the way that you were imagining?
Yes, I think that works, but I think maybe we should go through, and if folks want to be the person who does that, now would be a good time, realizing that we won't get someone for every one of these bullet points, and if there's additional bullet points that need to be added, I think now is the time to do that. Would you agree?
Yes.
Can I add? I think also would be an extra layer of protection if you want to. I would recommend, if this is for the task force, to have one from ACRN and then one from SURG.
Whoa, yes, that's exactly it. And Henna, I really would advocate for 2, so that the 2 can bounce their thoughts off of each other as they're collating the data.
That way you don't have to worry about affecting the 2 separate committees.
Awesome, thank you so much. I don't know if there's a person taking notes on this, but if we can draw this up in a way that is effective after we leave this meeting, that would be awesome, and really detailed, specific to what the group has agreed upon, and the guidance that Henna has given us. Lisa, please.
Thank you, Chair. Lisa Lee for the record. I do also just want to put a plug for 2 members, just so that it's not just a sole person's eyes on the data.
Oh.
I think that's best practice.
Absolutely. Thank you. I thought you were going to give us like 2 specific names. Like, I think Carissa should do this. And sorry, Shayla.
Shayla Holmes for the record. I would just like to advocate for transparency in the data collected. I appreciate the subject matter expert concept. I appreciate the need for somebody who is well-versed and educated in these specific topics to core, like to bring it all together for a presentation that is smooth and makes sense. But if there, I would strongly advocate for transparency of suggestions by all members that are inputting into those pieces. I would hate for there to be belief that there was a recommendation made that's evidence-based that was not aligned with a specific entity or individual's understanding and have that be lost. So I think transparency is going to be critical when it comes to this data / expert duoship leading the charge.
Agree.
I get where you're coming from, but I don't know how to bundle that as part of the I believe we might have to make a motion to like get this to happen by the end of this meeting, is like, you know, to assign, it's going to be confirmed that we're going to send out a survey, and then we're going to collect the data, and then we're going to get the 2 names of one from ACRN, one from SURG, that are going to be running the section on development of communication prevention, so on and so forth. Carissa?
Yeah, I was just, Shayla, to your concern, I think the intent, as I hear it, is to have 2 individuals with subject matter expertise collate the data so that we're not getting into the issues that start to go against open meeting law. But then they would present that to the full group. That would be the whole point, is then they would come back and present all of the evidence, what they collated, the summary of it all, so that it would be transparent. So I think we're trying to get to that place.
Shayla, that's kind of what I thought too. Shayla, does that make sense as far as the transparency that you're speaking to, or are you speaking to something different?
That makes sense as far as the transparency goes. And I think that the survey data collected could still be made available as perhaps backup documentation to whatever is presented by these experts that are going to be collating it and presenting it. So that way it's really obvious where they're perhaps grouping recommendations, however it ends up being presented, is coming from. Otherwise, it gives the belief that perhaps what was provided in those data surveys might be omitted, altered, things of that nature. So I think as long as the survey and the data collected through that survey is provided and clear as to how that led to recommendations and whatever is being presented, I think that for me, that sits much better, as opposed to I'm the expert in whatever, and therefore I don't think this recommendation is valid, so I omitted it. I think that that's what I would like to make sure we don't see happen, or have the belief by any member that that is what has happened.
Okay, good. That's I am better understanding where you're coming from, and I am seeing that by using the duo, one from each committee, we have a check on that, but also giving a thorough presentation of what information they gathered from the survey and how it applied to their the creation of their piece of the action plan. I think we'll be able to keep that all in check. Does that sound? Do we all sound? Can I get a thumbs up if that sounds right? Ish. Okay. Okay. Let's. I have Terry.
Chair, if I could. Yeah. I was just going to say, if I can add on this, we have 14. So if that would be 2, that would be 28 members. If there's other people want to add, then we could add those when we send out the survey. But what we were just thinking is, when we send out this survey, we could have members say which they want it to be on. That way, instead of trying to assign them that now, that would give people time to think about what they want it to do and which one they want it to help shepherd forward. So it would all be by survey. And then, of course, as always, we would have as backup documentation the survey results for each of the presenters' presentations on the day of the presentations.
Yeah, that's a good call. Don, can I get you to go back maybe 3 pages to the initial blank slate version of what Dr. Kerns and that'll do. That one's good too. Either one. But my question was going to be is, can this be a part? I mean, okay, up one. I'm sorry, up one. Can this be a part of the survey too? Because I wanted to add those questions that I had, but also like in regards to this blank form. Okay, cool. Okay, cool. Dr. Wagner.
Hi, thanks, Carla Wagner for the records. I just heard Terry say 14, but I know, and we talked about this last time, then Lisa raised it again. There was, I think Lisa has a 15th recommendation that it would be nice to get on here. Lisa, the one about working explicitly with communities of color. Are you imagining that that was a bullet point, like one of these 14, now 15 recommendations?
Lisa Lee for the record, yes, because I think if we're not addressing health equity and specifically racial disparities that we're seeing in our data, we're not doing due diligence.
Okay, so before we send this out, can we get the language for that and add that?
Yes, and I would ask that SEI, Kelly or Crystal help with that, because we did amend that language at our most recent meeting.
We have that from the SURG meeting.
Perfect.
So it was already in there and it just didn't get on this list. So we just have to pull it from that other document?
That's correct. I did add some things though, because I'm getting questions around, like, first of all, messaging around Good Samaritan. I don't think we've done that. We have messaging on a lot of things. There's still so much out there, so much misinformation and misunderstanding about the Good Sam law, that I think we've really not taken our opportunities to spread that message. And I think we could do a better job of communicating that. And then additionally, I've had some questions from folks around Good Samaritan law protections for undocumented individuals. And I don't have the answer for that, but I think it's very, very important that people are without documentation are protected in the event that they are calling on an overdose, especially given our high Hispanic rates of death across the state. So I think that needs to be a consideration. And I'm not a legal expert, so I'm not sure if there are protections around undocumented individuals. It's definitely not explicit in 453C. But I will also say that we can do better around communicating with Black and Brown communities, understanding that there's historical trauma and a low level of trust for law enforcement. And I think that we really need to be strategic around communication and utilize, there's tremendous resources across our state that are doing this work, that are not part of this conversation, that I think we can, yeah, they're already leading this work. And so I think that there's opportunity to support good communication strategy to ensure health equity. Thank you.
Thank you, Lisa. So what I'm seeing is that I'm not, again, sure if we need a vote or a motion to approve and push this measure forward, but if we do, I'd like some people to start thinking about what that looks like. And then basically we'll need to set a plan for SEI, state staff, and I would assume the chairs or me or AG Ford to get a draft and final draft of the survey put together and then sent out. Does that sound like close to where we're at? Dr. Wagner?
Can I volunteer to help you with that?
Awesome, thank you. I need lots of help. So
I think, Chair Sanchez, I do think we might need to take a vote on this because this was something that was listed for possible action, but I don't know that we still have a quorum. I think there's one member of the, I've been trying to count and I just am not sure how many members are present in Vegas. I think it's just one.
Okay, can we get a
Henna is actually, Henna's the expert on that. So if she can let us know if we need to check for a quorum and take a vote. I think those are questions on the table. And if we do need to take a vote, we need someone to make a motion that outlines the steps you described.
I do think a motion should be done, but there should be confirmation that there is still a quorum.
Okay, thank you, Henna, and thank you, Crystal. Can I get Dawn and Terry to confirm quorum, please? It does look lower, doesn't it? I didn't notice
We're
it.
here.
We have the same in Vegas, but I don't know. Do you want me to run through the SURG members to see who's still here?
Yeah, if I can get a quorum in SURG and a quorum in ACRN, it would give me a solid number for the task force.
Sure. Chelsea Cheatham.
Present.
Dr. Dixon.
Present.
Senior Danyate. Gina Flores O'Toole. Attorney General Ford. Senator Severs Ganthert. Shayla Holmes.
Present.
Jeffrey Iverson. Jessica Johnson.
Present.
Lisa Lee.
Present.
Debbie Nadler.
Present.
Angela Nichols. Christine Payson. Eric Schoen.
Present.
Steve Shell. Assemblywoman Thomas. Assemblywoman Hardy. Dr. Woodard. We don't have a quorum for a SURG. How many members do we have?
We have 7.
7 SURG members
Out of 18.
Out of 18.
All right. And I don't know if Christine Payson is here, but I have her name on the screen as an attendee and virtual. So I don't know if that was counted for or against, but 7 out of 18, you say?
Yes.
Dawn, what about us? ACRN.
Jessica Barlow. Brittany Collins Jefferson.
Present.
Lenitra Grady.
Present.
Ryan Gustafson. Dr. Kamiar.
Present.
Carissa Loper.
Present.
Catherine Loudon. Dr. Wagner.
Present.
Cecilia Maria. Elyse Monroy.
Present.
Darcy Patterson.
Present.
Pauline Sala. I think she left. Chair Sanchez.
Present.
Ariana Saunders.
Present.
Cornelius Sheehan. Jamie Ross.
Present.
Queenie Winbush. I have 9 out of 16, so I still have a quorum of ACRN. I guess we need to add those all together.
Yes,
That
it's
doesn't-
16 of 34. That's not gonna do it. 9 and 7 is 16.
Well, you need a quorum on both.
Oh,
So because it's a joint task force in order to take action. But what you could do is you could still lay out what you'd like to have done.
okay.
And you can have someone, volunteer to do the things that you're saying and get it started.
Okay. Can I volunteer / told Dawn to help me make a to at least distribute the survey, and then I have a volunteer of Dr. Wagner to help me create and then get to Dawn the survey, and then Dawn will get it to the SURG or the committee or the task force as a whole, and then. As members that are here of either committee receive the survey and you're interested in working on the actionable plans for any of the subsections like harm reduction or communications or access to care and treatment, I would please ask and advocate that you step up and offer to be a part of the duo. We're going to need one from SURG and one from ACRN to one, go over the results of the survey concerning your specific access to care and treatment and whatnot, and then get that information put together and provided in a presentation very similar to what we did here today. But this presentation then is not just one that's informational, it's one that we will agree upon and move action forward, or we will disagree upon, talk about it, and then move action forward. Can somebody help make sure that I'm not forgetting anything on the things that we need to take care of moving forward without a motion?
Chair, can I suggest when you push out the survey that you have the committee members maybe list 3 that they would be interested in, just in case we get a lot for one, so we can have more than one choice.
Yeah, that too is whatever duo is working on whatever portion. I would hope they don't come back with 13, and I also would hope they wouldn't come back with 1 actionable item. But you know, we will be cognizant of that. And yes, I will ask Dawn to keep me on task with remembering to add a message in there that we're not just expecting 1 or 100. We need, you know, a couple, 3 actionable items.
No, I'm sorry. I meant list 3 things that you would be willing to work on in case.
Yeah. No, that's super smart. Yes. Thank you. Redundancy so that we don't have everybody picking the same 2 spots from the same committee and we don't have anybody to work on the other parts of the goal. Thank you, Dr. Kerns, for clarifying, and sorry for Carissa. No? Yeah.
Yeah, oh, I was just Carissa Loper for the record. I was going to say maybe in there, Don, you could ask people to rank their top 3 topics they would like to provide input to.
Great call. Lisa?
I would like to volunteer to be one of the persons reviewing data for the harm reduction.
Good. Can I volunteer someone else for a different section? No, just kidding. Okay.
Is there anything on education and prevention? I'm sorry to interrupt. I'm sorry. There's so much data. I can't figure out what's what. This is Debbie Nadler for the record.
So Carla Wagner, if I could just interject, I think what we're talking about is asking people to volunteer for the ones that they want to collate and present in the survey. So we'll actually ask you within the survey, can you please identify 3 of these areas that you would be willing to co-chair as a member of the ACRN or the SURG to collate the data and present it back to the committee. So we can take care of all of that in the data collection exercise.
Okay, so we don't have to volunteer now is what you're saying. Okay, yes. Thank you. Sorry, thank you.
Yeah.
Thank you.
Here, Sanchez.
That makes sense. Yeah, Crystal?
I just wanted to note that SURG member Angela Nichols has joined. She is a new SURG member, and I just saw her come online. I don't know that changes our quorum situation, but I wanted to make that announcement.
Thank you so much. I appreciate that. That gives us 8 of 18 on SURG and 9 of 16 on ACRN. But Debbie did bring up something important to me. Looking at the very first sheet that we got out on the 2nd of November, there were 3 subsections: development of communications, harm reduction, and access to care and treatment, but there's not a subsection for prevention. Should there be, or am I confused?
It's under communications.
It's under communications.
Oh,
there's increased prevention in schools, education of the public.
Okay, so then if that's what your expertise is in, or if that's something that's important to you, keep an eye out in the survey to volunteer for that section, please.
Okay, sorry, this is Debbie Nadler again. When y'all send it out, will it show a breakdown of each one? If it has the education, it'll break down everything. Okay, thank you.
Yes. All right, then let's get ready to wrap up unless we have any questions, comments, concerns with the process that we set forth right now today. If there are none, then I want to roll us into 9, finish 9, get into 10 for public comment, and then wrap it up. Can I hear from some of the committee members that haven't spoken yet? Can I just get some input, feedback? Do you think we're headed in the right direction? Do you plan on participating in the survey and then in the possible opportunities to volunteer to help kind of correlate some of this
Chair,
data?
this is Chair. We did not schedule the next meeting yet either.
Okay. Yeah. So before public comment, I'll do the scheduling of the meeting. Does that sound good? Okay.
Yes.
Yes.
Thank you.
So this is Carissa. Can we do that without quorum?
You can, because it's not an action item. You can just throw out dates.
Thanks, Henna. Lonisha Grady, you unmuted yourself. Brittany, you also, yeah, please.
Yeah, I just want to say I support the current plan that has been set forth. So I support it. I think we're on the right road to getting things solved.
Good. Thank you so much for giving me that. I appreciate it. Brittany?
I just was responding to your question. I also am in support of the plan that was derived today. And I will also, I don't mind sitting on a board to help address some of the topics that we're going to be addressing.
Awesome. Thank you, Brittany. And I am going to ask right now, Dawn, can you just help me to keep in mind that on the informational part of the email when we send out the survey, that we just clarified that it is a two-person team that is going to be working on collating the information from the survey. Dr. Kamiar, did I see you on mute? Okay, maybe not. Maybe I was confused. Oh, there you are.
Yeah, I was just to say no. I don't think I am muted.
Okay, sorry about that. Debbie.
Yeah, if we're planning the next meeting, can we take in mind that the holidays are coming up and some of us are going to be going out of town until January 7th? Just saying for the record.
Come on, Debbie. I wanted to have it the day after Christmas so we can get to work.
My one vacation, I'm going to be gone till the 7th. Please, do we have to do it before the holidays is my question.
Okay. No. It's, well, I mean, I would like to get moving, but can we get some idea? I was going to text the state team, but do we have an idea of when the next time we want to meet is? Let's say...
The hope was, and what Dr. Woodard had suggested, was the end of January or beginning of February.
Yes.
I mean, I'd like to move it up 2 weeks and put us in the middle of January. Is anybody opposed?
This is Carissa for the record. I'm not opposed. I'm just, I am out of the country from January 13th through January 24th. So.
Lisa?
For January is I'm going to be out for surgery in February.
What was your dates again? Did you give them?
I don't have a date yet. I go see my provider on February 13th.
Okay, so the beginning of February is good for you?
Yes, sir.
All right, so let's stick with Dr. Woodard's plan. Right? Do we want to leave it tentative and then you'll get an email that tells you when it is, or how does this move forward, Dawn? Or Crystal, or Terry?
I was going to say, too, we want to do a doodle poll with a couple of dates at the end of January, beginning of February.
You are the best. That's exactly what we should do. So let's put it towards the doodle poll towards the last week in January and the first week in February.
Perfect.
And I guess we'll call that agreement on the next meeting. We have gone over our next steps, so I'm going to move from agenda item number 9 to agenda item number 10. I'm going to now open it up for public comment. Again, I'd ask that anybody available for public comment, please avoid repetition and limit your comments to no more than 2 minutes. I will be, again, rigid on the 2-minute timer, and no action may be taken on any item which may be discussed during public comment. And you're open to write in your public comment, and it can be submitted to the task force, and it'll be included in the meeting minutes. Do we have anybody interested in speaking as part of public comment? Checking participants digitally. Oh, I just closed it.
I don't see anybody with a hand raised that's joined virtually from the attendees.
Okay. Do we have anybody in person?
Yes, we do.
Okay, please.
Giuseppe Mandel, for the record, representing There's No Hero in Heroines, Alternative Peer Group, and Recovery Friendly Workplace. I just want to thank everybody for all the work you do. I know it's very tedious, seems like, in these meetings. And I know you felt maybe somebody like me feel a little good thing that I'm not the only one that has problems on computers. So it's quite intimidating. I appreciate all your hard work. I really do. And if we can ever be of service in any way, please let me know.
Great. Thank you very much for your public comment. Do I have anybody else digitally or in person for public comment at this time? I have Debbie Nadler.
Yeah, I just want to let everybody know speaking of there is no heroin, there is a very big event, February 13th, Monday, put on by Ten High. It's open for vendors. If you're interested, it's one of the biggest events in our city, if not state, and just mark your calendars. And Giuseppe, you can maybe explain more. That's my comment. Mark your calendar.
It will be keynote speaker Glenn Novak, and it is the largest resource here in the state of Nevada. So it is open for vendors and tables, as well as sponsorship advertisement. I don't know where I'm supposed to say that. But it's February 13th at Central Church.
In Las Vegas.
In Las Vegas, Nevada. For you.
All right. Thank you for your public comment. Do we have anybody else interested in public comment? Gonna check the participants list and attendees. I have no one with their hand up virtually. Anybody in the north or south in person that would like to speak now for public comment? This is the last call.
Also, if there's anybody on the phone that would like to unmute, that's the best way if you're only joined by phone. Sorry, Chair.
No, thank you. Thank you for doing that. All right, I'm not hearing anything. I'm going to move forward with agenda item number 11. Thank you so much for your time today, team. And let's just keep pushing one day at a time, one step at a time. We will get something done, and we're all working hard towards this. I appreciate you. This meeting is now adjourned.
Thank you very much. Very good. Thank you.
Happy holidays, everyone.
Happy holidays.
Bye. Happy holidays.